Hello, my name is Dr. Sarah Jarvis, and it's an absolute pleasure for me to be here today in conversation with Dr. John Eichelboom. He's Professor of Haematology at McMaster's University in Canada, one of the foremost centres for research and management in thrombosis and hemostasis worldwide. Dr. Eichelboom, welcome. We're going to be talking today about the things that matter to you and to me. I'm a GP. I deal with patients with atrial fibrillation every day. And sometimes we get into tiger country. It's scary stuff. Patients don't necessarily have all the inclusion and exclusion criteria from the studies. They may be frailer, older, have worse renal function. What do we do with them? What are the practicalities? Should we really feel confident managing these patients? And if we are going to feel confident, what sort of advice, what sort of help do we need? Stroke prevention in atrial fibrillation is a huge area for so many of us. It's now over 2 years since dabigatran was licensed for stroke prevention in atrial fibrillation in the UK, 3 years, of course, in the US, and about 18 months since NICE pontificated and decided that we were allowed to have it. Since that time, we've also seen rivaroxaban and apixaban licensed. What do you think have been the biggest challenges facing you and your colleagues since they came in?
I think there have certainly been challenges, and I think the implementation of change is sometimes the hardest thing that we face. We have anticipated for many years that we would receive alternatives to warfarin. They're suddenly here. It's like overnight, bang, here we have them. Now, what do we do with these agents? And they represent, for many people, a whole new learning experience. And folks look at the data and they wonder, I've been burned by a new oral hypoglycemic agent. I've been burned by a new COX-2 inhibitor. Are these new agents really what they're said to be? All this marketing, are the data real? Is the evidence tight? Can I translate that to my patient? I suppose if I had to summarize, it's the confidence that using these tools I can reduce the burden of disability and mortality due to stroke. And once I achieve that confidence, it's plain sailing.
In the first year or so after dabigatran came out, the press had a bit of a field day talking about adverse events. Needless to say, our prescribing advisors, some of whom might possibly have had a vested interest in scaring us, picked up on those. Tell me the real story. Should we be worried about this apparently hugely increased risk of bleeding?
I think you've nailed the experience for the first few months or the first year with the NOACs. And indeed, there were reports of serious bleeding with these agents. If we think about it critically, though, it's not surprising. For years we've had warfarin, and when is the last time that you or I reported a bleed on warfarin? We're not going to waste our time doing so. I think they call it the Weber effect, a new drug, lots of reports. To their credit, the regulators kept a steady hand on the wheel. They said, we're taking note, but we'll do our own investigation of these issues. And just in the last year, both the European and the North American regulators have come out with clear statements about the safety of the new agents in the real world. The FDA in particular have performed a very detailed analysis of population-based databases, and I think we can be very reassured that during this first couple of years since the introduction of the new orals, if they're used according to the way that they were tested in the trials, we're going to get similar efficacy and safety results.
One of the issues we seemed to be seeing that arose, I suspect, because people were very keen to have a NOAC, was that many of these adverse events occurred when people had been switched without getting their INR below 2, so they were doubly anticoagulated, if they had renal failure and were still using dabigatran, or if they weighed very little. How can we stop that from happening? How can we keep these drugs safe?
Well, I think we need to keep in the forefront of our mind that anticoagulants, even if they're good, even if they're very good, they're going to result in serious adverse events if they're not used properly. So when faced with a patient, I'm considering to start an anticoagulant, and let's say I'm thinking about a NOAC, I'm going to ensure that they're in the risk group, they meet the criteria to be treated with a NOAC. I'm going to be sure that their renal function is adequate, because all of the NOACs are cleared partly through the kidneys. I'm going to check on interacting drugs. There are a few drugs that will interfere with the NOACs. And I'm going to be sure that I've reviewed the history in terms of bleeding, so that I'm not putting a patient who clearly is at very, very high risk of bleeding onto a drug that could well cause another bleed.
These drugs are as good, if not better, than warfarin. They are as safe, if not safer, than warfarin. And in some patients, they may even be as cost-effective, if not more cost-effective, than warfarin. What arguments do you most commonly get from GP colleagues? Because there will be arguments out there for not using them, and how do you counter those?
Well, I think my family physician colleagues are very thoughtful when they consider the new orals. They want to be sure that they're doing the right thing for their patients. The questions that they ask are, firstly, warfarin has been with me for now 20 years. I've used it. I know it well. Warfarin is the standard of care. What's wrong with it? Why do I have to adopt this whole new area of new oral anticoagulants? And I can understand that sentiment, but we ought to remember that warfarin is not used in half of our patients, and it's poorly used in one half of those where we use it. The second common comment is, well, in fact, the absolute benefits of the new orals compared with warfarin is pretty small. The numbers needed to treat are substantial. We need to treat, on average, 100 folk to prevent a stroke. Now that is true, but again, we ought not to lose the sight of the big picture, that the new orals are in the first place here not to knock out warfarin, but they're here to provide us with additional tools to tackle that big unmet need. The third common issue that is raised by my GP colleagues concerns the period of evaluation of the NOACs. They've only been tested in the trials. Can we extrapolate to the real world? The answer to that question is absolutely yes. There are several million patient years of experience with new orals out there in the community. And we have community-based data, for example, from the Food and Drug Administration in the United States, on tens of thousands of patients started with new orals and compared with warfarin. And then the last big issue, should we be introducing a drug without an antidote? And on the face of it, a valid concern. But when we look at the trial data and we look at the population data, I think we can be very reassured that even without an antidote, these drugs, as you mentioned, are at least as safe, and in fact have lower bleeding rates for urgent interruption, have similar or lower case fatality rates after bleeding in the real world. So let's work with our GP colleagues through the objections, but I think we can point out, based on very robust data, that these fears are unfounded.